All right, thank you everyone for joining us tonight for our October presentation for Living Well with Cancer. We are joined by our guest speaker, Amanda Goodstadt, who is a staff attorney with Triage Cancer. And she is going to be talking with us about navigating health insurance and finances tonight. So if I could please just ask everyone to mute so there's no background noise. I am going to hand it off to Amanda.
Thanks so much, Jen, and thank you all for including me in this evening's meeting. It's nice to be back here with all of you. I was here last spring and I talked about employment issues, and this time, as Jen said, I'm going to talk about navigating health insurance and finances. Oops. Before I get into that topic, just a minute or two about Triage Cancer. For those of you who may not be familiar with us, we are a national nonprofit that provides free education on legal and practical issues that can impact people who've been diagnosed with cancer and their caregivers. We're really proud of the fact that all the services we provide are provided free of charge, because we feel strongly that someone's financial circumstances should not be a barrier to getting important information that can help them. We provide education in many different ways. We have a very robust website where you can find a lot of information, not just about tonight's subject matter, but about many different legal and financial topics that people have a need to learn about. I also have created a resource document that I sent to Jen and that she can distribute to all of you and to anyone else in the group, so that every time you see a link or I mention a particular resource during this evening, those are all pulled together in that one document. If you look at our website, you have access to information about our many educational events, including our free Triage Cancer conferences, our webinar series. We have access to lots of resources that are free and can be downloaded. Some of our most popular are quick guides, which are basically fact sheets that introduce you to or summarize important topics. We have a lot of worksheets and checklists to help you get organized and to work through different matters. And we have resources that are not written as well. We recognize people learn in a lot of different ways. So one of our most popular resources that's not written is our animated videos, which are brief 4 or 5 minute videos that introduce topics. I'm going to talk more about a couple of resources in particular later on, but I just wanted to give you an overview of what we have available. So let's get into tonight's topic. I think people are pretty accustomed at this point to hearing about the physical toxicity that is associated with cancer diagnosis, whether it's the toxins that might be linked to causing cancer, or whether it's the toxic impact that some of the treatments for cancer have on the body. Just as there is this physical toxicity, there is also financial toxicity, the negative financial side effects that are caused or exacerbated by a cancer diagnosis. And unfortunately, financial toxicity can be every bit as significant as physical toxicity. And not only can it impact the individual who's been diagnosed with cancer, it can impact their entire family. There are a number of factors that are going to impact anyone's overall financial health, but the one factor that we at Triage Cancer believe is the most significant contributor to financial toxicity is health insurance status. Whether someone has health insurance coverage, if they do, whether that coverage is adequate, and even if it's adequate, whether someone knows how to use their insurance effectively in order to minimize costs. Because we have found that the primary way to mitigate financial toxicity is making sure that people are using their health insurance properly. So that's going to be the focus of this evening's talk. So if we know that health insurance status is the most significant contributor to financial toxicity, it seems like in theory, it should be an easy problem to solve. But one of the challenges when we talk about health insurance is that it's such a complicated subject that many Americans just don't understand how it works or how to best select a health insurance plan for them. In fact, in one survey, only 4% of Americans insurance could define 4 basic terms that are used across all different types of health insurance policies when discussing the cost of care under those policies. So if you've always wondered about what certain terms mean, or you've been confused by some of the things that you've seen or read, you should know that you're not alone. It is my hope that after this evening, you'll at least feel a little bit more confident and feel that you do have the ability to choose the right health insurance plan for yourself. So I'm going to start with talking about those 4 basic terms that most Americans weren't able to define. These terms are used consistently throughout health insurance, regardless of how you get your health insurance. So whether you're getting it through an employer, whether you get it through the marketplace, whether you have Medicare, these basic terms are all consistent. And they all relate to cost. So first you have the cost just to have your health insurance at all. And that is your premium, a fixed dollar amount you are paying each month. And you're paying it whether you never go to a doctor or whether you're seeing multiple doctors multiple times each week. Then you have costs when you're actually using the health insurance. The first of those is your deductible. Again, a fixed dollar amount that you pay out of your own pocket before your insurance begins to kick in and help share for costs. Deductibles vary by plan. Some plans have very low or even zero deductible, and some plans have very high ones. Then there's a cost each time you actually go and get care, each time you go to a doctor or you go to a pharmacy. And those costs can be expressed in one of 2 ways, either as a fixed dollar amount, in which case it's called a copayment, or as a percentage, in which case it's called a coinsurance or a cost share. So if every time I go to my primary care physician, I pay $20, that's copayment. If every time I go to my primary care physician, I pay 20% of the total cost of the visit, that's a coinsurance or cost share. The final term on this slide that I want to make sure we all are on the same page about is out-of-pocket maximum. And again, that's going to be a fixed dollar amount. And that represents the most that you're going to pay out of your own pocket for covered medical expenses during the year. Once you reach your out-of-pocket maximum, your plan takes over and pays 100% of your covered expenses. How an out-of-pocket maximum is calculated is going to depend on your plan. So as an example, if you have a plan that you purchased on the health insurance marketplace, any amounts you're paying towards your deductible, any amounts you're paying as copays, and any coinsurance amounts are going to count when figuring out whether you have satisfied that out-of-pocket maximum. Let's just run through a quick example of how this works. So here's Dan. Dan purchases an individual health insurance policy on his health insurance marketplace. His plan has a $2,000 deductible. It's structured as a coinsurance, 80-20. Plan pays 80%, Dan pays 20%, and there's an $8,000 out-of-pocket maximum. Dan ends up in the hospital towards the beginning of the year with a huge $102,000 bill. What is he responsible for paying? So first, the first $2,000 is his deductible, and he does have to pay that out of pocket, leaving him with $100,000 of this bill remaining. His coinsurance is 20%. 20% of 100,000 is 20,000. But our analysis doesn't stop there. Because his plan has this out-of-pocket maximum, $8,000, and Dan has already paid $2,000 towards that, the amount remaining is $6,000. And that's all of the $20,000 that Dan will still need to pay, for a total of $8,000 for the year, at which point his plan takes over and is going to pay the remainder of that bill. Now, in no way am I suggesting $8,000 isn't a lot of money. Of course it is, but it's still a lot less than $20,000, let alone $102,000. I know I'm talking somewhat fast and trying to cover a lot of ground. If you wanted to hear this example again, or if you know someone who you think would benefit from hearing the example, it is in one of our animated videos about health insurance basics. A couple of nuances to the out-of-pocket maximum term. First, in the example I just gave you, I said Dan bought an individual health insurance plan, but as you all know, many people have family plans. So just be aware that if you have a family plan, there may be individual out-of-pocket maximums for each family member, as well as a family out-of-pocket maximum. Another nuance, I mentioned that Dan bought his plan on the health insurance marketplace. All health insurance marketplace plans define out-of-pocket maximum as including amounts paid towards the deductible, all copayments, and all co-insurances for both medical care and prescription drugs. But not all plans define that term the same way. So if, for example, you have an employer-sponsored plan, it might not include amounts paid towards your deductible. You might have to satisfy your deductible and then start on $1 of all your copayments and co-insurances to find out when you'll satisfy your out-of-pocket maximum. Or it might not include copayments either. It might only look at amounts you're spending towards co-insurances when calculating the out-of-pocket max. It also may not include amounts you're paying for prescription drugs. For some plans, they will have separate out-of-pocket maximums for those. There also can be separate out-of-pocket maximums for what are called out-of-network services. So more terms to know. Most health insurance policies in this country have a network of providers that they have contracted with to provide services for a set rate, a contracted rate, or an allowed amount. These providers can be doctors or groups of doctors, hospitals, therapists, labs, pharmacies. And essentially what the health insurance company does is it goes out to these providers and it says, we want you to be part of our network. In return, we're going to pre-agree that for various services, this is what the beneficiaries with our plan are going to be charged. So the best way to save money with these plans is to stick to seeing providers within the plan's network where you know upfront what you're going to be charged and that you're only going to be charged that allowed amount or that contracted rate. If you choose to go to a provider who is not in your plan's network, an out-of-network provider, it's possible that the insurance plan will not cover that at all, or it's possible that it will cover it, but at a different and usually higher rate. Another term you may have heard is prior authorization. This refers to an insurance company requiring someone to go to them before they receive services and get approval that the insurance company will in fact cover a service once it's provided. And this concept exists both for medical care and for prescription drugs. There's a bunch of challenges involved with prior authorization, one of which is that it isn't always called the same thing. So just be aware, sometimes it's called pre-authorization, advance approval, prior approval, lots of different words, all with the same general meaning. Another challenge is that usually we do not see insurance companies providing comprehensive lists to patients of what services will require prior authorization. Sometimes you might get a list, but not always. We find that frequently the services that require it will be the bigger services, the more expensive services, things like hospital admissions, surgeries, or specialty tier drugs that are really expensive. But it is always best to ask and make sure you don't need prior authorization, because if you don't get it, you are risking having to pay the full cost of whatever service or drug is the subject of the prior authorization. Some healthcare providers are very helpful. You might find that your doctors will help you with this process, but ultimately know that it is the patient's responsibility to get the prior authorization. Unfortunately, we have seen situations where even if someone appropriately and properly gets prior authorization, that the insurance company could still turn around and not pay for a service. But know that if you're denied a prior authorization, you can appeal it just as you can appeal denial of coverage after the fact. A couple of more terms related to billing that are good to know. This slide shows you two of them. I'm actually going to start at the bottom with balance billing. Balance billing refers to billing a patient for the difference between what a provider charges and what an insurance company pays. Balance billing only exists with respect, or is only allowed, I should say, with respect to out-of-network services. And that is because if you're seeing an in-network provider, you may recall, that in-network provider has agreed to an allowed rate with an insurance company. And so they're not allowed to balance bill a patient for anything else. An example, just quickly, provider charges $100 for a service. The allowed amount is $70. A preferred provider or an in-network provider cannot ask the patient for that $30 balance, but an out-of-network provider can. Totally separate from balance billing is the concept of surprise billing. That's a little bit different, or I really should say it's completely different. Surprise billing can come up in a situation such as patient needs surgery. Patient does their homework, they select a surgeon who is in network in their plan, and they have the surgery performed at a hospital that is in network for their plan. During the surgery, it turns out they need anesthesia. And the anesthesiologist is not someone who the patient selects. That person is assigned by the hospital based on who's on call. Patient is discharged from the hospital, gets a bill from the anesthesiologist only to discover that they were out of network. That is a surprise billing situation. Many states have comprehensive laws that protect patients in these situations. There are some other states that have less comprehensive protection. They mostly are to protect for emergency room visits when those emergency rooms are out of network. But some good news that some of you may have heard about is that as of the beginning of this year, we have a new federal law in all 50 states that protects people from certain surprise billing situations. It requires that insurance companies treat surprise bills from out-of-network providers as if they came from in-network providers. It applies to the kind of situation I just described, where you get a surprise bill for non-emergency services that you received at an in-network facility. It also applies to emergency medical services. It even covers air ambulances, but unfortunately does not cover ground ambulances. There are some other related provisions. Out-of-network providers are allowed to ask patients to waive their rights under the No Surprises Act if they are getting non-emergency care. And if a patient refuses that, the provider is allowed to refuse care. But again, that's for non-emergency situations. Providers cannot ask patients to waive rights in situations like the anesthesiology example I just gave you, as well as for certain other types of situations where care from an out-of-network provider is going to be the only option. The government, in implementing the No Surprises Act, has set up a 1-800 number, a toll-free number where you can call if you have an experience that you think falls under this and it wasn't handled properly, and also has a way to file complaints online. Final slide for terms is a slide dealing with prescription drugs. So a few terms to know about here. The first is formulary, and that is just a list of drugs covered by your insurance policy. Formularies are broken down into tiers. Policies can have different number of tiers, but in general, the lower numbered tiers are where you're going to find your less expensive drugs, like your generics. Higher numbered tiers are where you're going to find more expensive drugs, like specialty drugs, newly approved drugs, many of the drugs that are used to treat cancer. Each tier can have its own payment structure. So some tiers may have co-payments, some tiers may have co-insurances. It's important to know that not every drug is covered on every formulary. And so if you fill a prescription for a drug that is not on your plan's formulary, you are responsible for 100% of the cost of that prescription, and the amounts you pay are not going to count towards your deductible or towards any out-of-pocket maximums. So now that we covered all these terms, remember, they're important regardless of how someone gets their health insurance, but it's good to just have a reminder of where it is that Americans usually get their health insurance. There are three main places Americans look for health insurance. First is through an employer. And by that, it could be your own employer, it might be a spouse's employer, it might be a family member's employer, it might be retiree coverage through a former employer, and it might be COBRA if you are continuing the same coverage you had while actively employed if your employment ends. So all of those fall in the part of this pyramid that says employer. The second major place Americans get their health insurance is through the government. That could be Medicare, the program for people who are over 65 or who are disabled and have received 24 months of Social Security disability insurance benefits. It could be Medicaid, the program for people who have low income and in some cases low resources. It could be through a variety of military plans, the Indian Health Service, or even some state high-risk pools. The third major place Americans get their insurance is privately, directly from an insurance company. And marketplace coverage would be included in this part of the pyramid, because even though those state marketplaces are regulated by the government, ultimately, when you purchase your policy, you are purchasing it directly from a private insurance company. At Triage Cancer, we believe that it's important that you know about all of your health insurance options so you can pick the best one for you. Many people don't even realize that they may have options. They might only know about one of their options. Unfortunately, tonight, we don't have time to delve into the details about all of these options, but do know that we have extensive resources to help you understand any or all of them. And I want to particularly point out 2 recent webinars that we did that have been recorded and are accessible through our website, one of which is entirely about Medicare, and one of which is about understanding health insurance in general, but which goes into much more depth about the marketplace and about Medicaid. In addition to knowing what options you have, it's also good to know when you can take advantage of an option. When can you enroll, or when can you make a change to coverage? So for employer plans, that's going to vary based on the employer. It is often in the fall, but not always. So you need to talk to your human resources person or benefits person about that. If it's Medicaid, applications are accepted year-round. If you think that you have become eligible for Medicaid, you can apply whenever you need it. For Medicare, the enrollment period that applies to all people with Medicare is the fall annual open enrollment period. It just started a couple of days ago on October 15th, and it runs until December 7th. You can make as many changes to your Medicare as you like during this period, but the last change you make by December 7th is the one that will become effective on January 1st for, in this case, the 2023 calendar year. And the marketplace similarly has a fall open enrollment period. The federal marketplace and the states that use that marketplace, the period is November 1st through January 15th. But some states have slightly different and longer enrollment periods. In New York, the enrollment period lasts until January 31st. Just note that if you want coverage that begins on January 1st, you have to enroll before then. You can't wait until the end of the enrollment period. So once you narrow down your plan options and you know when you can enroll, you need to know how to compare your options. So I want to walk you through an exercise to compare costs. The exercise is useful to compare different types of insurance. Maybe you're comparing an employer plan to purchasing a marketplace plan, or maybe you're going to compare 2 different marketplace plans. Maybe you're going to compare your employer plan to a spouse's plan. Maybe you're even going to compare Medicare Advantage plans. Just to make things simple, I'm going to use 3 marketplace plans to compare. I'm going to take a bronze plan. And for those of you who might not be familiar with the marketplace, they have different medals that describe the terms of their plan. So they have bronze, silver, platinum. First, we have a bronze plan with a $200 monthly premium, a $6,000 deductible, and an $8,000 out-of-pocket maximum. Next, a silver plan with a $275 monthly premium, a $2,500 deductible, and a $6,000 out-of-pocket maximum. And finally, a platinum plan with a $400 monthly premium, 0 deductible, and a $2,000 out-of-pocket. maximum. So let's assume that someone has a cancer diagnosis and is thus going to hit their out-of-pocket maximum during the year, because when we're talking about the cost of cancer, the likelihood is pretty high that that will happen. Can we tell just by looking at this slide which of these plans is going to cost the least by the end of the year? So since not everyone's visible, I'm going to just go ahead and you can all be thinking, what your answer is. But I'm going to say, no, we can't tell just by looking. We have to do some math. I find that when working with people about health insurance options, there is often a very strong desire to focus on premiums. And I understand that, right? Because the premium is a fixed price. You're paying it regardless of how much healthcare you're accessing during the course of the year. But a premium doesn't tell the whole story. Remember, the first slide I talked about with terms has all these different terms that pertain to cost. Unfortunately, looking at health insurance is not as easy as going to the supermarket and looking at the price of a dozen eggs, where we can look at a label and just clearly see one price tag associated to one product. In this case, it's not enough just to look at premiums. We have to do math to calculate total costs. So in this case, the way we do math is, in this example, we're going to multiply our monthly premiums times 12. And then we have to add to that amount the out-of-pocket maximum for each of these plans in order to see total cost. When we do that math, plan number 1, that bronze plan with the least expensive premium, comes out to a total of $10,400 for the year. Our silver plan totals at $9,300, and our platinum plan, where maybe you had sticker shock because the monthly premium was twice that of the bronze plan, that comes out to be a savings of more than $3,000 over the bronze plan. So it turns out that by doing this one exercise, someone has saved several $1,000s. Now, of course, cost is not the only thing to think about when you're looking at the differences between plans. It's step 1. Step 2 is looking at networks of providers and facilities, making sure that the people that you want to see or the facilities where you want to be are covered by the plan that you select. And step 3 is looking at prescription drug coverage. Are the drugs you take covered on your plan's form or the chosen plan's formulary? Are they there at a price that's affordable? And even if they're on the formulary, are there any restrictions on getting those drugs? Because a drug can be on a plan's formulary, but still require prior authorization, or perhaps something like step therapy, which refers to having to demonstrate to the plan that you have tried a lower cost drug for the same condition and it didn't work. The Marketplace website allows you to see which providers are part of which plans, as well as whether certain prescription drugs are covered. New York State of Health, which is the New York Marketplace website, also allows people to search for plans by entering particular provider names. And for those with Medicare, there is a comparable tool called the Medicare Plan Finder on its website. It's also really important, even if you're using a website, to do your homework on this, to double check with the providers themselves. When you do that, and when you're searching for plans using either healthcare.gov or New York State of Health or Medicare.gov, please make sure to use specific plan names. It's not going to be enough to just say, oh, do you take Blue Cross or Humana or Aetna or whatever insurance company name, because all of these companies have hundreds of plans. So it's super important to be very detailed and use the exact name and sometimes number to make sure that the plan you are looking at is accepted by your providers. Often, large providers will list on their website a full tally of all the plans that they take. And it's also really important to let your providers know if you are making a change to try and facilitate that transition. Sometimes it can feel like selecting the right plan is easier said than done. This is so critical to your finances that we have created several resources just around this concept. So the information I just talked about is in an animated video about picking a health insurance plan. We also have a worksheet that we developed. There's a picture of it on the slide where all you have to do is fill in the blanks. It's good for people like me who maybe are not the best with math. It really walks you through things step by step. And we have a different worksheet that is specific for people with Medicare, which again walks you through all the ins and outs of how to do a comparison. It is really important to note that choosing a health insurance plan is not a one and done activity. You have to continually review your coverage at least once a year. Circumstances can change. So for example, maybe you stop working, maybe you change jobs, your health situation may change. Perhaps you go from not needing any treatment to needing treatment. But even if your circumstances stay the same, and even if your health situation is stable, keeping the same insurance, that insurance can change its costs and coverage from year to year. So it's very important to make it an annual habit of looking at your coverage. When it comes to the marketplace, there are people out there who can help you, people who are local to you. They're called assisters. You can search for them by zip code on the marketplace website. And what's special about these folks is, in contrast to insurance agents and brokers who may be very knowledgeable, assisters have no financial interest in the decision that you make. They are trained and certified to provide objective information. I do want to say just a little bit about Medicare. Since we're in open enrollment, I'm the one who gave our Medicare webinar. It was 2 hours long, so I'm going to try and do the 20-second version of that, or maybe a little more than 20 seconds. But basically, if you have Medicare, you have two main lanes that you can drive in to get your Medicare coverage. Your first lane is original Medicare. That's where you have the government Part A for hospital insurance, other inpatient coverage. You have Part B, which a lot of people think of as their medical insurance, medical coverage for doctor's visits, therapists, lab tests, etc. If you want prescription drug coverage, you have to select a separate Part D Medicare prescription drug plan. And if you want some help, because original Medicare has no out-of-pocket maximum, so if you want some help covering the out-of-pocket costs that are associated with Parts A and B, you can also purchase a separate Medigap plan or supplemental insurance to help with those out-of-pocket costs. That's lane one. The other main lane that you can drive down in Medicare is Medicare Advantage plan, where you select a private managed care plan through which you're going to get all of the coverage that you'd otherwise get through original Medicare. So that's the plan that you're looking to if you have a hospital admission or you have a doctor's visit. The vast majority of those plans include drug coverage, but if you happen to select one that doesn't, you have the option of picking up a separate Part D plan. What you can't do in lane two is get a Medigap. And the reason for that is because all Medicare Advantage plans have out-of-pocket maximums. So since I don't have time really to go any more in depth about Medicare, I do just want to mention a couple of places you can look for help if you have questions about it. Medicare actually publishes a very useful desktop guide that they send out to beneficiaries every fall called Medicare and You. If you have Medicare, you should have gotten it or should soon be getting it this fall. But if you don't, you can also download the PDF from Medicare's website. Medicare has a great tool that I referenced earlier called the Plan Finder, where you can go on the website and get a lot of information about what is available in terms of prescription drug plans and Medicare Advantage plans. They allow you to call their 800 number, and if you say agent, you can talk to a human being there 24 hours a day, 7 days a week. And another program that I want to make sure everyone is aware of is the SHIP program, State Health Insurance Assistance Programs. Every state has one. They are kind of like the assisters I just mentioned to you for the marketplace, or it's actually the reverse. SHIP has been around longer than the assisters, but SHIP has volunteer counselors who will talk to people with Medicare and walk them through their options for how to get coverage. In New York State, the SHIP is called HICAP, or the Health Insurance Information Counseling and Assistance Program. They found a way to make a long acronym even longer. But HICAP is a great program, and it may be a good source for information for those with Medicare. So the reality is, even if you have adequate health insurance, it's probably not going to completely eliminate all of your medical bills. So I just want to spend a couple of minutes talking about some strategies related to those. Each time you go and get health coverage or health care, I should say, you're going to get a lot of correspondence related to every one of those visits, right? First, you're going to get correspondence from your insurance company. The amount is going to vary by company. There are some companies that are going to communicate quite a bit. They're going to tell you each time they receive a claim. They'll tell you when they're processing your claim. But I would argue the most important correspondence you will get from your insurance company is your explanation of benefits, or EOB. This slide is meant to show you what an EOB might look like and give you the types of information you're likely to find on one. First of all, you're going to see somewhere in big letters, this is not a bill, because it's not a bill. This is an explanation of what a provider has billed your insurance company for, what your insurance company believes they are allowed to be billed for, what they're paying, and what they think you may have to pay. It's going to have some information on it about who the policyholder is, member and group numbers, who the patient is that they're talking about. It's also going to have a summary. It's going to say, we were billed X amount, we approved benefits Y amount, and the amount you may have to pay for this service is Z amount. Then it's going to go into some more detail. It's going to tell you the date of service. It'll tell you where the service happened. It'll give you some coding information so you know how the service was explained to them. It's going to break down what they were charged. It's going to show you the total amount charged, what they allowed, and what they ended up paying to the provider. And then it's going to break down what they think you're responsible for. Show you, was something applied to your deductible? Was it a co-payment or a co-insurance? Was any of this not covered? And somewhere, hopefully, it's also going to show you, after processing this claim, here's where you stand with respect to your deductible and with respect to any out-of-pocket maximums. Just as your insurance company is going to send you some mail, so is the provider. And generally speaking, they're sending you one thing, and that is the bill. Unfortunately, in our experience, usually the provider is a lot faster to send out a bill than the insurance company is to send out an EOB. We really urge you, if you can, to wait for the EOB before you pay a bill to make sure that it is, in fact, been submitted to your insurance company and processed correctly. Keep track of these things. Match your EOBs up to the corresponding bills. And communicate with your provider. You can call them and let them know, hey, I have this bill. I'm not paying it yet because I'm waiting to see how it was processed by my insurer. It's important to review bills for accuracy and to not be afraid to speak up. Ask your provider to clarify codes if you don't understand what things mean. And review your explanations of benefits as well. What I sometimes find in talking to folks is there's is sometimes a desire to not really look at the bills. I've talked to more than one person who will tell me, I just have a box and I put all my mail in there because I don't feel up to dealing with it. I can't deal with it. I understand the desire to do that. It is obviously not a strategy we would recommend, but it is a kind of thing where when we hear people say, I have all these friends and relatives asking me, what can I do to be helpful? Maybe this is something they can do to be helpful. Maybe someone can help with opening mail. Maybe they can at least match up the EOBs to the bills and figure out what may be duplicates. And if you can't deal with the bills yourself and you don't have someone in your life who may be able to help you, you should know there are professional bill review services and medical claims organizations out there. Another thing to really understand is that you can appeal any denials of coverage. The vast majority of Americans do not appeal coverage denials, even though if you look at statistics, many of these coverage denials are reversed, even just with going through one step of the appeals process. Besides understanding all of those terms I talked about earlier, another way to really make sure you're effectively using your health insurance is not accepting no for an answer. Appeal things that you think should have been approved. A couple of basic tips for this. First of all, you have to know what type of insurance plan you have because the appeals process varies not only depending upon your insurance company, but also depending upon what kind of insurance you have. So there are different processes. If, for example, you have certain types of employer-sponsored plans or Medicare or Medicaid. It's also really important to find out the reason for a denial. Sometimes claims are denied for administrative errors, coding errors. Sometimes it's more complicated and the insurer is questioning whether something is medically necessary. If your denial is medically related and not an administrative issue, it is really critical to get your healthcare provider involved with your appeal because the insurance company is going to be looking to see what evidence can be submitted by your doctor to demonstrate, for example, if they denied something based on medical necessity, that in fact it is necessary. It's also really important to make sure that you have a copy of your plan and copies of all of your copies of all the relevant medical records. Appeals, again, is a subject that we could speak at length about. I know I just went through that very quickly, but know that we have a lot of resources available on our website to help you with the appeals process, including things like how to get copies of your medical records and various forms to help you track the appeals process. Now, if you're in a situation where you do in fact owe money to your healthcare provider, you can try talking to them. We suggest doing it earlier rather than later. We want it to happen before a provider turns over unpaid bills to a collections agency in order to help protect your credit. But you can ask for more time to pay. You can see whether a provider will write off a portion of your bill. You'd be surprised, but providers sometimes do that just because you asked. You can try and negotiate a payment plan. You can try and see whether a provider will take a lower lump sum payment in exchange for not having to wait out getting payments over time. And we sometimes see these strategies work with non-healthcare provider creditors as well. It is also super important to keep accurate records. Keep all of your medical bills, keep all of the correspondence from your insurance company, all your EOBs, all the pre-authorizations. I like to suggest that people keep a small notebook where they jot down dates and names and outcomes of any kind of correspondence they have. Like they call the insurance company, who did they talk to, when did this happen, and what did the person they spoke with say? You want to keep all of these records in case you have future billing issues. You also want to keep records for tax purposes in case some of your expenses are deductible. And you want to keep copies of medical records in case you need them in the future. One relatively new resource we developed to try and help people with medical bills is our medical bill tracker. It opens as a spreadsheet. It opens as a Google Sheet. And what you can do, I just blew up part of it so it's easier to see on the slide. You can fill in your deductible and your out-of-pocket maximum for your plan. And then as you get bills, you can record them down at the bottom. And as you put the amounts in, the spreadsheet is populated or programmed so that it will show you what remains towards meeting your deductible and towards your out-of-pocket maximum. So if you're getting EOBs and they are not doing this math for you, this is a way to be able to do this without having to set it up yourself. A final note about medical bills. We had some good news last year about medical collection debt. All three of the major credit reporting agencies announced that effective July 1st of this year, If there is paid medical collection debt, it is no longer going to be included on people's credit reports. They also extended the time period before unpaid medical collection debt is going to appear on people's credit reports. It had been 6 months, it's now 1 year. And effective at the beginning of next year, medical debt under a certain amount is no longer going to be included on people's credit reports at all. And it is said that this one action by these credit agencies is going to remove nearly 70% of medical debt in collections accounts from people's credit reports. So it is a great step forward for consumers. I want to quickly talk about what happens even if you do your best to choose the right health insurance, to manage all your medical bills. Sometimes people still end up in situations where they just don't have sufficient funds. They still need help. So I want to just mention a resource that we created on our website called cancerfinances.org. This resource provides practical information on various topics that can impact your finances. It's designed to guide you to information that is relevant to your situation, and does that by first asking you to select a module. We have a lot of modules. The list on this slide is partial, but you go to the module of interest and then you're asked a series of questions. And based on your answers to the questions, you're led to information that hopefully is on target for answering your question. One of our modules is about financial assistance specifically, and it has subtopics for all different types of financial assistance. Like maybe you need help with home care or with transportation, or with hearing aids or dental care or what have you. And what we have done is we've tried to collect information about all these different organizations that are out there that have various programs where they provide varying levels of financial assistance to folks. Because these are mostly private organizations, they set their own criteria. So you have to look at each organization's guidelines to see if you would fit into their parameters. Sometimes the folks they want to help are regional, right? Like the organization is based on where someone is located. Sometimes their help may be based on the type of cancer someone has been diagnosed with. So you have Susan G. Komen for breast cancer, or you have Leukemia and Lymphoma Society for blood cancers. Sometimes programs are geared towards people who have children with cancer or single parents, or it really runs the gamut. But what we've tried to do is make things a little easier for folks rather than just Googling and kind of seeing what comes up. We have created a list where we try to put in a brief summary of what an organization does. You can go through the list in the topic of interest. And then if you see organizations that stand out to you as possibilities, you then are led to their website, given contact information. We have another module that is specifically about financial assistance with prescription drug costs, because that is such a hot topic that we're asked about. One of the places that I always like to remind people can be a source of help for this is the pharmaceutical company that makes the drug in question. A lot of times people only realize that they can go to the pharma company because of a copay assistance program. And they either know that they're eligible for that copay assistance program or they know they aren't. But really, a lot of the drug companies have folks who are trained not only to screen for their copay assistance programs, but who have other knowledge about the practical issues people face in paying for their drugs. So they may have information about navigating the prior authorization process. They may have billing and coding information that's useful, where they can tell you right away something seems off with how your prescription was coded. They may have resources for denials and appeals. And of course, they also may have direct financial assistance or programs to give trial vouchers or free drugs. So we really like to encourage people to go back to a pharmaceutical company if one has a program for them, and we have a way of locating the appropriate company on our website. Another resource when it comes to prescription drug costs is we have a Triage Cancer drug discount card, which we offer in partnership with another nonprofit called Needy Meds. This card is free. You can download it from our website. You don't have to register for anything. You can just print it out. Your whole family can use it. Basically, for Needy Meds program, they have a huge network of pharmacies nationwide where by showing this card, they offer discounts, sometimes significant ones, on a variety of drugs. Now, obviously, not every drug is part of this program and not every pharmacy takes part in the program, but I like to mention the Needy Meds card because it's a reminder that your pharmacist can also be a source of good information about how to get prescription drugs for less. Because they, like the pharma company, are seeing repeat customers, lots of people coming in and asking about the same drug, whereas it may be for you the first time trying to fill a prescription for a drug. And finally, I just want to mention, I talked about all the resources available through our website. I gave you examples of other places to go for help. One of the programs that we provide free of charge is our legal and financial navigation program, where we provide free one-on-one help to people who've been diagnosed with cancer, to caregivers, and to healthcare professionals. We recognize that sometimes you can read over materials and still not really have an answer to how does something apply to my particular situation. So if you've been listening to me tonight and you're thinking to yourself, gee, I have questions about some of these things, and I'm not really sure what to do with these questions now that I have them, I encourage you to reach out. It's very simple to start the process with us. You just go to the link on the slide, and the link will be in the resource document that Jen has as well. You fill out a pretty brief questionnaire asking you about your situation, and then you're prompted to schedule a phone call back from a member of our staff at a time that's convenient for you. We call you. When we do, we'll ask more questions. We'll talk about your situation. And then what we will try to do is explain options you have, provide you with accurate information. Sometimes that involves us doing some research, so we may have to schedule a second call. But we do all of this with the goal of trying to empower you to be able to take next steps and to advocate for yourself. And we get questions on a lot of different topics. Health insurance is a very popular one. Employment, disability insurance, finances, estate planning. But really, we get questions from a lot of different areas. But we really do our best. We're a small staff, but we are really dedicated. We want to help. So if you feel that you could use this sort of one-on-one assistance, I invite you to take advantage of it. And with that, I know I've spoken for a while, and I want to say thank you all very much for sticking with me. I know sometimes it's not the most exciting topic, but I hope that it's been helpful, and I'm happy to try and answer questions if people have them, or otherwise to let you, get back to the rest of your meeting.
Thanks so much, Amanda. I'm going to stop the recording. So if anybody wants to ask anything, please